All right, so again, we're going to hear from Dr. Dorothy Rhoades on building partnerships for health, collaborative cancer research with tribal nations of Oklahoma. And I'd like to first just briefly introduce our presenter today. Dr. Dorothy Rhoades is dedicated to addressing cancer disparities in Native American communities. She earned her medical degree at the University of California, San Francisco School of Medicine and her master's in public health and epidemiology at the University of Washington School of Public Health. Currently, Dr. Rhoades is the director of the Native American Center for Cancer Health Excellence and professor of medicine at the OU Health Stevenson Cancer Center, University of Oklahoma Health Sciences in Oklahoma City. She's a member of the Kiowa Tribe of Oklahoma, and Dr. Rhoades has researched health disparities for decades, spending the past 13 years building collaborative research projects with tribal nations and their health systems to address cancer prevention, screening, and access to care. Just a few highlights of her impressive career in public health. She's an accidental academic, now professor of medicine. Only 0.2% of full professors in the School of Medicine are American Indian or Alaskan Native. She's been a hospital-based physician since 1997. Former Tobacco Settlement Endowment Trust Scholar at the University of Oklahoma. So we're very excited to have Dr. Rhoades with us today and again sharing her work, helping us further our mission of CISEP by learning about her work in Oklahoma. All right, so we have our first poll everywhere question. So feel free to use the link provided by Andrew in the chat in pollev.com and enter UNCLCN and feel free to respond to the question. The question, no universally accepted term describes the descendants of the pre-colonial inhabitants of this continent. So like most people said that is true. All right, so at this time, please give it up for Dr. Dorothy Rhoades while she talks about her collaborative cancer health research with tribal nations in Oklahoma.
Thank you very much. You can still hear me okay, Ryan?
Yep.
Yeah, okay, great. All righty. So thank you very much for that introduction. And I want to thank CISEP for the invitation to present here. And I also want to thank the staff who've been very patient with me as we work through this, getting the presentation together. So I'll be talking about the experience I've had with my colleagues here at the Stevenson Cancer Center with tribal nations in the state of Oklahoma to build a research program to address cancer, the multiple disparities. So I don't have the little link to advance at the moment. There we go. Oops. Okay, so the objectives are, so I'll kind of give a background on the cancer health disparities, the trends in cancer epidemiology among American Indian populations. Then I'll kind of talk about the development of partnerships and how this has led to us moving into an area of collaborative care. And so we'll talk a little bit about the collaborative care that we're doing currently. And then describe what we're calling the C3PO. It's a current project that we have, Care Coordination and Collaboration Program in Oncology for Tribal Health Systems, which is something that we're really trying to bridge the gap between the cancer center, the academic cancer center, and the Indian Health Service and tribal health and urban programs who refer patients to us. Excuse me. So, as you all already know, based on the responses from the sample poll, that there is no universally accepted term. You'll probably hear me using some variety of multiple of these terms here because American Indian Alaska Native is what's being used as a federal race classification For a lot of the data and statistics, you will hear me use American Indian primarily, and that's mostly because I focus in on Oklahoma. The vast majority of Native Americans in this state are American Indian. Um, Also, just a reminder, I'm not sure this audience really needs it, but whenever possible, tribal nations and tribal names when you're working with folks, but these are also political entities rather than what a lot of people assume are racial or genetic determinations. So just as also a reminder, the work that we've done in building our cancer research program is always awareness and respect for tribal sovereignty. And as quoted by the National Congress of American Indians, again, this is not something that necessarily derives from race or ethnicity, as tribal members are citizens of three sovereigns, the tribe, the United States, and the state in which they reside. And also acknowledging that we have a legal right to health care services. This is based on a long history of treaties and other legal actions across the years. Excuse me. And just a little bit of background again, that this number in terms of, I'm so sorry, excuse me, the 6.3 million American and Alaskan Native population in the US alone or combined with another race. As you all probably also know, this number tends to kind of just go up and down or up and down because it's difficult to describe who is or who is not American or Alaskan Native, whether it be from the census or other sources. But there are 574 federally recognized tribes, and these are dependent sovereign nations. And there's several more state recognized tribes, some very large ones that we all already know. We got to thank the folks here at SciSep are very aware of this as well within their own state. It's estimated nearly 3 million people are served by what I'll be calling the ITU system, the Indian Health Service, the Tribal Health System, or an Urban Indian Organization, which operates facilities across 37 states and at least 14 million outpatient visits. And over here, you can see the per capita expenditure estimates. This is from the Indian Health Service fact sheet, which estimated that the per capita expenditure in 2023 for the Indian Health Service was $4,078 compared to something that's even 3 times higher. After I created this slide, I started kind of digging down to find out, well, where exactly did we get these numbers? And I believe, to be honest, that this 4,078 is the exact same number that was found by the Government Accounting Office in 2017 when they were tasked with what was the per capita expenditure. And this is the exact same figure that's been used in subsequent IHS fact sheets. So I strongly suspect that the expenditures have gone up because this figure here comes from like the Kaiser Family Foundation estimates, and they update it every year or so in terms of the U.S. national healthcare expenditures. There's no way that even if this is a little bit larger now in terms of the IHS expenditures, that we come close to this 13,000. So I just kind of wanted to say that as I realized I just took those numbers at face value. And so I think we need to kind of update what this number is, just so we're clear. And as a reminder for the ITU system, it is split into several different service areas across the United States. And the ITUs, they provide direct care services right within their facilities. But for specialty care, it requires contracted health services. As you can see from that previous slide regarding the relative expenditures, there's not a whole lot available to the ITUs. So very, very few, if any, have their own specialty services, and that includes oncology care. So somebody has cancer, they have to be approved through the purchase and referred care. And you're only eligible, there's certain eligibility at one facility, if you are not do not meet the residential requirements, that ITU may not be able to cover your care. Also, just in case this audience needs it, while all descendants of American Indians, Alaska Natives are eligible for health care direct services from Indian Health Service, they may have access to all other sorts of public or private funding, and that IHS is not an insurance company, and it doesn't quite operate the same way insurance does. It would be the payer's last resort. So if you're Native American, it doesn't mean your care is only from the ITUs. And sometimes that's also for general researchers, they're just not quite aware of how this is different than the general population. So a little bit of the cancer epidemiology in brief, and I will lead with the good news that the overall cancer mortality across the United States, regardless of race or sex, it has decreased for the past 2 decades. So this is really the good news. We're all happy to see that. The disparities remain significant. So for this time period on the slide, the overall cancer incidence rate was the highest among American Indians and Alaska Natives of all racial and ethnic groups. This also held for women when you subdivide by sex. We also found that cancer incidence rates were increasing among younger American Indians and Alaska Natives, including children, adolescents, and young adults, whereas it has been decreasing among the white counterparts across the United States. Cancer mortality among the racial ethnic groups is second highest for American Indians and Alaska Natives. The African American Black rate is highest in the United States. So kind of coming into what we are doing in Oklahoma, this is our estimated American Indian population. Roughly 16% of the state is American Indian alone or in combination based on census data. As you can see, these are all tribal jurisdictional areas, which encompasses a good 3/4 of the state of Oklahoma. Oklahoma has 39 federally or state recognized tribal nations headquartered here. We have the second largest population of American Indians or Alaska Natives in the United States, second to the state of California. But we also have the second highest proportion of the population that is Native, with Alaska having the highest portion of the population that is Native. And with all these different tribal nations headquartered here, I lifted this from the First Americans Museum, which is a relatively new museum in Oklahoma City. And as you can see, we have very rich, very varied, and diverse cultural traditions across the state of Oklahoma. As many of you probably know from your history, is that many of the tribal nations that are currently headquartered here came from vast distances across the North American continent to Oklahoma involuntarily. But this is home now for quite some many, and I'm happy to say we definitely celebrate our culture and our traditions. So here's our first poll in terms of the Oklahoma. The cancer mortality among our American Indian population exceeds that of the state's non-Hispanic white population by about how much? We'll give about 30 to 45 seconds to see if anybody wants to venture some guesses. Okay. And looks like a lot of you already know. So for the 5-year period at the top of the slide, the all-cause cancer incidence for American Indians in Oklahoma, the incidence rate ratio was 1.5, so roughly 50% higher than the non-Hispanic white counterparts for the state of Oklahoma. Incidentally, this is a fairly high incidence rate. Oklahoma already has a fairly high incidence rate for cancer, but that for American Indians is even higher. These are data that have been linked to IHS to reduce the problem with racial misclassification that occurs with a lot of administrative and vital event data. And in terms of mortality, looking at this for the major racial groups in Oklahoma, you can see the American Indians also have the highest cancer mortality rate. And that also clocks in right about 50% higher when you look at the mortality rate ratio. So we have pretty substantial and persistent cancer disparities in the state of Oklahoma for the Native population. These disparities begin at relatively young ages. This top solid blue line is the incidence, the rate of new cancers for American Indians, Alaska Natives in the state, and by age. And you can see compared to the non-Hispanic whites, which is the dotted, it starts diverging right through middle age and all the way into older age. Mortality rates, similarly, they start to diverge even during middle age and remain that way. And the gap actually seems to be rising with advancing age. So looking at some specific cancer disparities here. So the leading causes of cancer death for Native Americans across the U.S. Is, and also in Oklahoma, is lung. That's by far and away the highest. And in Oklahoma, we have a high rate of lung cancer mortality. But even so, in Oklahoma, as compared to non-Hispanic whites, our mortality rate ratio is 40% higher, 70% higher for mortality for prostate cancer, 30% higher for breast, 80% higher for rectum. Again, these are by far and away the most common cancer mortality and causes of cancer mortality in our state. And I think that also is reflected nationwide. 30% higher for pancreas, but almost a threefold higher mortality rate for liver cancer. And you can see some of these other disparities as well. So rates of cancer screening in the Native American population. This is our next poll. The poll is just very broad. Cancer screening, of course, there are multiple types of cancers that have screening for them, and I just kind of lump them all together. Just to like majority say that it's lower than in the general population, and that's still true. So it shows that breast and lung cancer screening are the lowest among American and Alaska Native people compared to the other races and ethnicities across the United States. And also lower, it's not necessarily the lowest, but it was below other races and ethnicities for cervical, colorectal, and prostate cancer screening. And just looking at what's happening with the cancer screening in Oklahoma for these years early in this in the 2020s. The blue lines are the Oklahoma American and Alaska Native non-Hispanic population, and these are our rates of screening. So for breast cancer, it's actually not too bad, and these oranges is the United States white non-Hispanic population. The orange is the white non-Hispanic population. Right here in the gray is the United States, American Indian, Alaska Native overall estimates. So Oklahoma Native American for breast is better than the Oklahoma. We're worse than the country at large, but we're better than Native American rates overall. We do have a breast and cervical cancer program. We've had that for decades. But as you can recall from that previous slide, we still have a significantly higher mortality rate. So there's this disconnect between decent rates of mammography versus our breast cancer mortality. So we can also see how this goes for colorectal and prostate, and you can see lung cancer screening across the country. is not particularly very good. These numbers, I think, have merged since we made this slide. They kind of go up and down, depends on what source you're looking at. But it's relatively low still for the American Indian population, which has, in general, not universally true, but in general, especially for here in Oklahoma, the Southern Plains, the highest rate of cigarette smoking. And those rates persist. So I'm going to move over to the Stevenson Cancer Center cancer health disparities. And I've been with the Stevenson Cancer Center since the end of 2012. And the Stevenson Cancer Center was established in 2011. And there was no program within this new cancer center that was specifically addressing cancer health disparities for the Native American population, despite being quite aware there was. And so the Cancer Center said, we need this program. Myself and my partner, Dr. Mark Dosher, to come out and see what can we do to address some of this. So our principles were always that the research that we wanted to do maintain respect for tribal sovereignty, data sovereignty, community engagement at minimum, and community partnership whenever we could. So we've been trying to adhere to some of those principles. Since 2015, we have not just us, but across the Matrix Cancer Center, we've had more than 44 extramural awards that most of them have been research, but we also have education and outreach awards. To date, now we've managed to grow from zero to about $58 million. We have engaged at least 30 tribal nations or tribal organizations that serve tribal nations. We've had full partnerships with 11 tribal nations, also 12 tribal or urban Indian organizations. And for the educational grants, tribally led or native enrolled schools, we have 6 of those. So as our cancer program, research program had grown, we realized there's increasing interest in helping with addressing the cancer health disparities. But there is a disconnect between the protection for tribal and data sovereignty that comes when working with a tribal partner. They get to set those rules. And here at the Cancer Center, where we see American Indian patients, we take samples, we have their racial data. How are those data being used? And we want to be sure that they're used in a respectful way that meets some of the goals of our referring tribal partners. So we created a tribal advisory council to the Stevenson Cancer Center in 2020 that's comprised of leaders within public health, within the American Indian community. We also have tribal leadership as well represented in this. And our focus was, let's help guide the Stevenson Cancer Center on principles of research that are done out of this university. We have come up with some draft guidelines, and whenever somebody wants to work with me and they've not had any experience, I kind of give them these guidelines as to, I need you to do this minimum background work so that you can understand at least the history, and you have to understand tribal sovereignty, the historical abuses of research. And as much as possible, we try to get people out to actually meet the community. And we are about to meet later on this summer to try to make this a change this from guidelines to kind of mandatory. Whether or not we'll be successful, I don't know, but we'll be meeting with tribal IRB partners, as well as our institutional IRB partners, as well as interested parties to see, is this something we can do? Can we initiate this at the Cancer Center, make it mandatory? Also, as we grew, and we wanted to be sure we did not neglect outreach and education, as well as starting to help with policy, the Cancer Center invested in the Native American Center for Cancer Health Excellence in 2024. And I was named the inaugural director of that. So those are things that we've really worked towards. So I'll tell you a little bit about our research efforts. So probably this audience doesn't need to be reminded about what community-based participatory research or the historical misbehavior is for this particular issue about research, as well as healthcare in the American Indian community. But we really wanted to maintain our partnerships and our engagement. We know that it just takes just one breach of trust that can destroy the entire program. So when we got here, there was no program per se, and we said, okay, well, we need to build some partnerships, and we kind of reached out and said, we're here, we have a certain amount of expertise, we want to help address the problem that you're seeing in the community. And it happened so that at one of these meetings, Choctaw Nation was telling us that, well, they are seeing an unusual amount of skin cancer. So skin cancer is not the first thing that you think about in terms of cancer health disparities. But they were seeing that and they wanted to know why. So not funded by anything except for our time, we partnered with Choctaw Nation, who helped us administer a survey to the youth to find out, what's happening with some protective behavior. And this is just one of the highlights that we found, that we had 3 to 5 times the rate of tanning, both indoor and outdoor, boys and girls, compared to other youth in the United States. We had some other findings specifically around, the use of sunscreen, et cetera. But we did take that back to the tribe. They put it into the tribal newsletter. We were allowed to use the study to testify before the Oklahoma Senate to pass a bill that bans indoor tanning for youth under age 18. It also allowed supported a program for putting sunscreen in Oklahoma City parks. So as we were building this relationship, we were also interested in emerging risks versus potential protective factors. I was interested in whether vaping was going to turn out to be a gateway to more tobacco use in youth. On the other side, we were wondering, could vaping reduce the harms associated with cigarettes among people who are already smoking? So with the SEED grant, we administered a youth survey about their vaping patterns across IHS facilities in Oklahoma. And again, we found that there was a very high rate of vaping in American youth compared to U.S. youth. When we did this and we were talking and presenting our findings for both these studies out, it led to a partnership. This was with Cherokee Nation, where we got a center grant. One of the research projects was vaping among American adults who smoke. And this was a true partnership with the P20. With co-PI, I'm co-PI with another investigator from Cherokee Nation. And we had several publications from this. The big one at the time showed that vaping was not associated with smoking cessation or reduced cigarette consumption or reduced biomarkers of use. We found that this is likely because a lot of this was dual use. And so we looked at factors that are associated with dual use. I think since this time, research has suggested that vaping can be successful when a person completely stops combustible cigarette use. So we've also been exploring other factors that were associated with the dual use and the patterns. They're a little bit different in the Native American population than in other populations. Well, this led to additional grant funding that looked at potentially reduced exposure products, meaning things that might have less nicotine in them among the smokeless tobacco users, because we know that smokeless tobacco has been surprisingly not very well studied. So this received some funding and found that people who were using PrEPs who were smokeless tobacco users were not really using them as cessation users, as additional sources of nicotine from the tobacco. We did have the publication out of this. That led to 2 more research projects on another P20 Center grant, where we looked at electronic cigarette use among American Indian women. And this is just finishing up, and we have a manuscript in preparation. Also looking at tobacco cessation among American cancer survivors with this P20. So this is kind of how we started. We also know that that there's a perception in the general research community that Americans are anti-research. We have found that they've been very pro-research as long as that research has meaning to the tribe in real time. We're not talking 20 years later because you saw those mortality and incidence statistics right away. So we wanted to turn our attention to implementation science, and we were building implementation partnerships. So this included the tribally engaged approaches to lung cancer screening. This is where we provided our implementation science expertise to help the tribal health system implement their own lung cancer screening program. And those data, that project recently ended, and we are now in the midst of writing our findings for publication and dissemination for those. But it's been very encouraging in terms of increasing the rates of lung cancer screening. And I think it's been so successful that I think those lung cancer screening rates in our state are going to go up for that project. We also implemented a colorectal cancer screening across the ITU spectrum. So Indian Health Service facilities, the federally administered, the tribally administered, as well as urban programs. And we worked with those each kind of individually, each set to find out what their current processes were, what could be done to improve those screenings, and rely on their expertise as to what's going to work in their system. And they came up with some wonderful ideas, such as we called it the flu fit type drive-by. Because COVID is going on, so there was flu shots that were being given in the drive-through flu shots. And at the same time, for people eligible, they got a fit card with a mailing envelope to send it back in. That's just one of several techniques that have been used. Also, this is fairly recently completed. We are also working at those results. So this is this is what we've done, and the results have to go through peer review before we disseminate them widely. But we also had at the Cancer Center a Native American navigation program, and we had two projects. One that started with looking at the financial hardship screening, something that had not been done with Native American populations before, and we worked with our navigation program to try to get some of this information, and that directly led to us getting another grant from the American Cancer Society, which finishes in June of this year, about enhancing the capacity of what we have for the Native American navigation program. And I'll be talking a little bit more in detail about what's going for this, because this is where C3PO directly developed out of as well. But as we were building all these, we wanted to be sure we had components of bidirectionality. For some of these projects, after the TAC was formed, we took the ideas to the TAC. And for example, the navigation capacity building initiative required clinical trials education, and an optional metric that they wanted us to gather was enrollment in clinical trials. We took it to the Tribal Advisory Council. They said education is wonderful, but that's one directional. You need to make it bi-directional. Do your researchers, do they understand the historical mistrust that our communities have related to research? And so we included in there grant rounds. We've given grant rounds to hematology, oncology, as well as GYN oncology here on clinical trials education for the researchers so they can understand the concerns of the community. And that led one of the junior oncology faculty said, well, this is important. Why don't we know this? Why don't we know all this information? And she got a grant to create a curriculum for medical students, residents, and fellows. And that is currently also available right now. She's already had 80 responses, which is good. It's all voluntary. And has found the rates of the preliminary results of folks have gone from not being very comfortable at all discussing Native American research with Native American communities to much higher percentages. So this is how our TAC, it's just, I know people say this, that, oh, it makes so much sense that you need to get the people who are most directly affected involved in how you plan and design your research. And this has definitely enhanced what we've done here. So that just kind of is one example of this second statement here. A lot of our projects have community advisory boards as well. And also this just kind of helps us make sure that we're thinking of the Indigenous perspective as we do research. The Tribal Advisory Council is also very helpful in us finding out what the priorities were. We kind of, Ivory Tower-ish said, okay, we've got a Tribal Advisory Council. Why don't you guys tell us what should be our priorities? And they said, well, you got to go out to the community. You got to ask them. So we co-designed a survey with just these 11 items, having them kind of establish whether this was not helpful at all the way up to extremely helpful. And this is the rankings for the type of research or outreach that was checked off as extremely helpful. So early detection and screening, cancer prevention, and communication between cancer care and primary care providers are the top three concerns. And so some things that we had already been doing with American Indian cancer screening was the early detection. For example, you heard me mention that lung cancer screening that was in a tribal health system. Well, this experience led us to successfully getting funding for a second lung cancer screening in tribal health system. This one is enhanced further by having a more systematic approach to tobacco cessation to our screening. I know it's supposed to be part of lung cancer screening anyhow, but we thought, well, can we enhance this to improve that? The colorectal cancer screening project I mentioned also directly led to a supplement for follow-up of abnormal screening tests. We found that the rates of returns of those colorectal cancer screenings was great. It's good. And we said, okay, so what's that happening? How many cancers are we detecting? Well, the follow off before you got to the diagnostic colonoscopy is significant. So they got the tests, yay, the counts will go up. What happens next? We have to actually make a dent on reducing cancer mortality by doing something about these cancers. So this led to this project, which is looking up to find out what are these barriers for getting that positive test and getting to the diagnostic test and treatment. And also, Dr. Dosher is one of the multiple PIs for the Vanguard study. This is the multi-cancer detection assays, the blood tests, which can detect multiple cancers in the bloodstream. This is already available at some facilities, but we don't really know that it's going to be impactful in terms of reducing cancer incidence mortality. And so we were one of a few centers across the United States to participate in this cancer screening research network by the NCI. And ours is called OK Trust, the OK Tribal Rural Urban Screening Trial Access Hub. This was funded a year and a half ago. A lot has been in planning. It is about to launch nationwide. And we established a tribal research oversight board because the universal consent and the universal data management was all, everybody's going to get their blood samples. It's going to go to a central repository at the Fred Hutchinson Cancer Center, and it's going to be banked there for use by whomever, whenever. That is usually a non-starter for tribal partners. And we went to our tribal partners. They said, that's a non-starter for us. We took it back to the Vanguard folks, and they have said, yes, this is important data. We need to collect it. We will have our system to make sure that if the biospecimens are coming from tribal communities, that those are not accessible to others without getting permission from the communities themselves. So we're very pleased about that. This is just a little bit about the Vanguard study. In terms, they're going to test two different types of multi-cancer detection assays and have a control arm and be a randomized controlled trial. But this has the potential for revolutionizing cancer screening, assuming it works and is deployable. Okay, so this kind of leads on to the next half about our care coordination. So this is the next poll. Which of the following outcomes have been demonstrated by research to be improved by use of a navigation program? Yeah, I made this purposely fairly leading. Good. So this one was easy. All of the above, proven benefits to navigation and care coordination, not just in the American Indian populations, but just about anywhere it's studied. It shows that good care leads to better outcomes. Okay, so we know that patient navigation provides logistical and supportive guidance for patients throughout their trajectory, and that can improve outcomes. There are few Native American specific navigation programs for patients with cancer, especially in academic cancer centers. There are some, but there's relatively few. And we just kind of answered this question. So access to care. So at the Cancer Center, we have American Indian Navigation Services, and this is to assist the patients in the what can be complex and somewhat unique logistical and cultural barriers that arise as patients are moving between the ITU systems and the Cancer Center. This was from the very beginning of the Cancer Center. Two tribal nations made generous donations to the Cancer Center to support this navigation service. And here's a little word. But back in the 2011, navigation was just about any kind of navigation that could be done. These are not clinical navigators. This is not nurse navigation that we had at the Cancer Center. But it was the only program that we were aware of in the state of Oklahoma. And we have had at least very close to probably by now 4,500 patients that have gone through this navigation. And because Oklahoma is, to use the word, a melting pot of different tribal citizens, there are 65 different tribal affiliations that have been self-reported through the navigation program. Our program has statewide reach. So here we are in Oklahoma City, and these show all the zip code counties where patients have come from. So we hail from all across the state, so 200 miles. Some of the extremes, maybe going on to 300 miles that come to the Cancer Center. And the Native American Navigation Capacity Building Initiative had several components. I already mentioned the clinical trials education, and these are some of the other things that we looked at. But I'm going to kind of focus in on this huddles between tribal health and the Cancer Center, because we thought this is an opportunity for us to reduce no-show visits, for example. And can we, our navigators are fairly good. They've got good contacts with each individual ITU. They have a patient, they will call, or they'll call back and forth, they will talk. We thought, can we make this a little more systematic and make sure that we address problem X, Y, and Z? Sometimes a tribe may have transportation services that the Cancer Center is not aware of. Vice versa, the Cancer Center might have transportation gift cards available that the tribe doesn't have. And if we put people together before the patients come in, can we address what's going on? So we talked about some of their patient concerns, their trajectory, and then follow-up. There were some challenges in terms of clarifying the structure of this because it's not been done before. And then the technical issues about encrypted patient data, sharing those data, how we do this collaboration across the systems. So we did this with one ITU partner. And at first, there was a little hesitancy by the people who were actually going to have to do this, our navigators and the PRC staff. But once it went in, we actually found it was well received by both our Cancer Center staff and the ITU staff that we were partnering with. And that led us to another grant. So this is the Improving Cancer Outcomes in Native American Communities, and we call it ICON grant that we received last September. For a substantial amount of money, which we're very grateful to have had. And there are multiple PIs. I'm one, Dr. Dosher is one, and Dr. Spicer, who led one of those P20s before, also has extensive experience working with tribal nations as well. But our 3 research projects are included in this, and they cover the same priority areas that we have found from our tribal survey, our tribal outreach survey. So we had a project on prevention, a project on screening, as well as this care communication and coordination. The first, this was prevention one. We are using data to look at heavy metals in drinking water and linking them with cancer incidence and mortality using the Strong Heart Study data. And then we're going to take this information back and develop tribal or community-specific intervention plans to reduce their exposures of these heavy metals. We've also got a lung cancer screening. I've already mentioned that. This is the second one that we've had. And then this is our care coordination program in ecology for tribal health systems with C3PO. And there's multiple project leads for this one. Dr. Janet's and Dr. Nip have been they're actually the leading architects of this. So what I'm presenting is a lot of what they helped put together. But we have a very, very large crew, very active crew on this project. We also have tribal health advisors on our actually paid by us for this grant. These are folks who previously worked on community advisory boards for different projects, and their information was just so helpful. We said, let's do what this grant wants us to do to incorporate into this knowledge. And so they are members of our research team. They will help us design and troubleshoot instead of designing, troubleshooting, take it to a cab and bring it back. We also have a cab on this. But we have at least 8 investigators have extensive professional or personal experience working with or within tribal nations and communities. And the other goal of this is that, as we all know, there are communication gaps between specialists and primary care practitioners. This is just a handful of studies that have looked at that. A lot of these are talking about survivorship care. So as if the oncologist handles the whole patient while they're getting the treatment and then after. We're actually also interested in what is happening now with treatment, because we've seen this from our navigation program, that there are needs that patients have that the cancer center is either unaware of, either the cancer center is aware of or the primary care is unaware of, but each one might think the other one is taking care of a problem. So we wanted to know, can improvements in care coordination and communication help the patient outcomes for these IT patients who are in active treatment at the cancer center? And this is based on collaborative care models. Dr. Nip had worked with Dr. Irwin previously looking at collaborative care models. And these were things that were developed initially in the field of psychiatry. And the model is that, the patient and the oncologist interacting, and then psychiatry kind of comes in. And then there's a navigator who might be able to help us, but the navigator, the loop is not closed. So the thought was, well, let us do this the way tumor boards work. This is kind of how tumor boards work. Where the oncologist, the psychiatrist, and the navigators or other supportive staff, they talk about this patient and to try to come up with plans. So the collaborative care, there's a lot of evidence that this works. A lot of these have been in these different fields, as you can see: pain, mental health, cardiology, diabetes, post-hospital care. But now we're looking at it in terms of cancer. It just seems like a natural fit for cancer. And Dr. Nip has developed this for patients with cancer that he has received funding for. It had not been Native American populations, but it's clearly got the expertise to help us with our projects in terms of getting a lot of these experts on board so that we can help with either symptom burden, functional outcomes, etc. And we're also trying to develop a geriatric oncology care model at OU, so expanding it here to also include geriatric oncology. What we've done for C3PO is we kind of took that model. So the ITU facility generally is the one that suspects or comes out or gets the diagnosis, and that's with the patient. Then the patient is referred to oncology. And our navigators help coordinate the patient getting care at the cancer center. Who gets the CAT scan? Can it be done at the ITU facility, or does it have to be done at the cancer center? And they will help navigate those roles. So what our goal is, again, is to try to get the navigator, the oncology team at the ITU facility, all talking to be proactive about this care coordination. And it's not just missed visits. Now we're going to include Dr. Nip, a general oncologist, to discuss are there symptoms if there are symptoms that need to be addressed, who is the best person to do that? Would that be the cancer center folks, or is this something primary care folks? What if it is their chronic disease, their diabetes that's being affected by the cancer treatment? Who's going to help coordinate that? So that's the goal of this project. I'll just jump to kind of what our outcomes are hoping to be, because we know it's only a 5-year project and it's taken a year to get the preparation done. We can't really look at survival, but this is ultimately what we're hoping to improve. But we're going to be looking at patient satisfaction, the number of missed visits, time to treatment initiation, and hoping that there will be fewer treatment interruptions with this. These are all the implementation science metrics that we're looking at. We are also going to be looking at costs, both in time and money. We based our framework on the NIMHD framework that's been adapted for American Indians and Alaskan Natives. The grant asked us to make sure we had some sort of indigenous knowledge incorporated. We chose the 2IC model, which I frankly think that we are kind of doing it anyhow by incorporating the vision of indigenous knowledge, people with indigenous knowledge with our Western ways of knowing. And this was our logic model. And in the interest of time, let's just go on. And what we've done, we developed our community advisory board. We are starting to interview patients about their experiences with interacting between the ITU and the Cancer Center. We have interviewed the Cancer Center staff already. We are going through multiple IRBs before we can actually do this ITU staff huddles. What we need is the questions that we want to know. How is communication going? Will huddle be useful, feasible, sustainable? And just a little bit of information about themselves. Also, what are estimates about the costs that are going to be? We're going to be reassessing this throughout the project. And we are hoping to start the open pilot in our year 2, which begins in July with 1 ITU. And this is going to be for 3 months where we'll discuss patients and we're going to work it out, see how it all works. And we're going to take the rest of the year to incorporate those suggestions to go to an RCT, a randomized controlled trial by patients. And so initially this will be randomized, but after a patient has been in for 6 months, all patients will be considered for the C3PO program. Usual care is still our navigation program, our Native American navigation program, as has always been going along. This is actually something that a lot of cancer centers don't already have. So we've already got kind of enhanced usual care for our system anyhow. This is just our flow chart about how we're planning on conducting this study, the RCT. Okay, and then there's all the references that were requested. So thank you so much. I appreciate your attention and I'm happy to take comments and questions.
Thank you, Dr. Rhoades. Feel free to everybody place your question and comments, again, using poll everywhere.
Well, I'm happy to know if anybody is doing something similar within your systems that we could learn from. I would love to hear about those.
All right, well, if we don't have any questions or comments for Dr. Rhoades, again, I appreciate everybody joining us for our and continuing our SciSep webinar series. Oh, sorry, we do have one question. So what are some barriers on establishing some of this coordination that you see currently?
We see the interaction with our clinical delivery system, which is but both at our cancer center as well as ITUs, they are clinical delivery systems. They are not research. They're not research labs. So it's real world. And so the purposes of our working together is taking quite a lot of time through the administrative folks and making sure that this will fit into their workflow. But that's the whole purpose of this. We want to do what we can to improve the healthcare delivery. So a lot of those barriers are simply administrative understanding. The question about the return on investment is always a huge one. For example, navigation, we know it works to improve outcomes, but how do you convince the health system to pay for those navigators? So clinical navigation is now reimbursable by Medicare. I've heard that as in early days of adoption, it was just a little too hard for some places that they are not actually trying to bill, others are. So it's a work in progress. And we don't have reimbursement for things like screening navigators, which I think you want to talk about your biggest bang for your health buck. That would be it to prevent those. So that's what we see the most is making sure that that clinical delivery system can see the value and worth in terms of not just financial or finding a way that we can show that the cost is worth it, but the actual health outcomes are good. The ITUs, they are working as hard as they possibly can to deliver care that can, but as we know, limited resources. So when they help out and contribute to their services to try to do some of this work with us, we're very grateful. But again, it is every time we take something for this grant, is it taking something away from their own delivery system? They need every minute of that staff person's time. So we want to make sure that it's useful for both of them. So I think that's probably the biggest barrier, showing that can this improve the health of the patients. Thank you for the comments. So barriers, time and resources, time and resources, time and resources.
Okay. Well, again, thank you everybody for joining us. Again, thank you, Dr. Rhoades, not just for being our CISUP webinar speaker, but for all the work that you're doing in Oklahoma that, I think as we've seen really radiates, across the country. And I'm glad that we're able to learn from you and collaborate and work towards the same mission to better cancer health outcomes in indigenous populations. So thank you. Thank you everybody for joining us. Again, you can find our previous CISUP webinars on the recordings on the Lineberger Cancer Network website at learn.unclcn.org/CISUP if you'd like to see any of our previous webinar speakers. All right. And thank you to University Cancer Research Fund and again our collaborating organizations that make up CISUP, not just UNC, but Duke Cancer Institute, HM Health, Wake Forest Baptist Comprehensive Cancer Center. And thank you to our very own UNC Lineberger Cancer Network for providing the infrastructure to support this webinar series. And Tim Poe and his entire team for all of their hard work in making these webinars possible.